Yet in 2 seconds.
Yes, now it is, I think.
Yeah, now it is live.
Yeah, good evening, everyone. So this is the seventh class on reproductive immunology from the past 1.5 weeks that we have started. I think after having very good feedback on reproductive immunology, we thought we'll just add the POC karyotyping to this list of topics that we have added. And as I think as somebody who has been doing obstetrics and infertility too. So we get more and more of these situations where reason for the miscarriage, and this is parental karyotyping and all those difficult decisions which we have to counsel and take a proper decision to do it or not to do it. So with this class, I hope that all of you get clarity as to what is to be done, what is not to be done, and how to do it, and what value it really adds to your management of recurrent pregnancy loss. Yeah, over to you, sir. I mean, you can take over.
Sejal Ben, hello. But this is I'll just share the screen. Okay, and I will just start with immediately with the flow chart. Okay. Uh, Visible, na, Shilpa madam?
Yes,
Screen is
yes.
visible? Okay. See, it's a very, very simple thing. Okay. And just follow this in your practice. Basically, when there is a first IVF failure, okay, or when there is a first abortion, okay, you don't treat that particular thing or don't investigate. Don't treat and investigate. Okay. Now, irrespective of the age, if there is a second pregnancy loss, okay, if there is a second abortion, so let me just call it as pregnancy loss, okay, then you can consider to do product of conception karyotyping. All right. Now, product of conception karyotyping, first please remember that it is a specialized test. Product of conception karyotyping is a very important test. You need to send the sample. Okay, you need to send the sample in a buffered normal saline. Don't put formalin inside that. Okay, there is a buffered agent in which you need to sell the sample. Do not just go by the standard karyotyping, okay, which is called as G banding, which we normally do. That is probably not the standard of care. Of course, the standard of care has gone towards doing something called as microarray, because when you do a microarray, you basically you do not require the cells to be cultured. Okay, cell culture is not needed. Okay, why it is cell culture is not needed in this is because when you look at microarray, the cells which are lysed, you are just doing a polymerase chain reaction. That means you are just amplifying the genes which are present inside that. So this can be done basically on any of the platforms. NGS is one of the best platforms to look into it. Otherwise, the standard microarray is also good. The problem with G banding is something called as maternal cell contamination. Okay, MCC. It is called maternal cell contamination, and maternal cell contamination can occur very frequently when you have not taken the sample correctly. Okay, there are also some problems if the placental tissue is inadequate. Okay, in all those situations, doing a product of conception karyotyping through the standard G banding is not going to be adequate. So just keep in mind, this is your standard technique. I'm writing it in blue, and this standard technique may or may not be effective. Definitely the method of choice is to go ahead and do a microarray. Okay, definitely. Okay, definitely. That's the word. So that is your most important take home point. Obviously, microarray is a little expensive. It is going to cost you anywhere between 16 to 25,000 rupees based on your arrangement with the laboratory. Okay. Now, what to do as far as the POC karyotyping report is concerned? Okay. So you only have 3 reports, which one can probably think of. Okay. First report is that there is aneuploidy and chromosomal abnormality. Okay, for the product of conception. Nothing further to be done. Okay, why nothing further to be done? Because it was a bad embryo? Nature and God, both these people decided to abort it. You don't be over smart and go and then evaluate all these things. Okay. Second report is euploid embryo. Euploid embryo got aborted. मतलब अच्छे आदमी के साथ में बुरा हो गया, है ना? When a euploid embryo gets aborted, when a good person, something bad happens, we all feel bad. This is a situation where you should feel bad. And I have told this before also. Investigate this patient for immunological issues. Of course, the other issue where all these things is commonly seen is if there is an anatomical problem. But anatomical problem, I believe, at the first abortion itself, you would have done a 3D of the pelvis and you would have isolated the anatomical problem and would have corrected it. So I am not mentioning it. But your euploid embryo is a bad thing. अच्छे आदमी के साथ में बुरा हो गया. This is what we teach our nurses. This is what we teach to standardize this. So just keep that in mind. Okay. And the third report is again very interesting. You can have report like balanced translocation. Okay. You can have report like deletion. You can have report like inversion. Okay. In all this situation, before you do anything random, please do karyotyping of couple. Very important, huh? Because this karyotyping of couple, when you do, that is usually the cause for having translocation, deletion, and inversion. And remember, when you do microarrays, the good thing which you get in product of conception is you will also pick up small, okay, single gene defects, nucleotide arrangement defects and all these types of things. And then you will be able to counsel this couple if they will require a PGTA in the future to conceive with IVF or not, because that is very, very important for you to understand. Okay. In product of conception karyotyping, this is all you need to know. There is nothing beyond this. It is only this much. And this is the only flowchart which you should keep in mind, because this is going to conclusively give you an answer to almost everything that you have to do practically as far as POC karyotyping is concerned. Okay. Of course, if there are more questions to small aspects of it, why QFPCR? Why not NGS directly? Why not whole gene exome sequencing directly? Then we can probably touch upon that, but I think they are not needed. By the time you reach till there, some geneticist will be involved, some genetic counselor will be involved. All these laboratories where you are sending these reports, they have on-panel genetic counselors who are geneticists to guide the patient about that. So, I mean, unless you want to discuss that, we can discuss that or have a separate session on genetic counseling as to how a clinician should do genetic counseling rather than a geneticist doing a genetic counseling. Okay. But otherwise, POC karyotyping, this is it. You can take POC karyotyping with your standard MVA, that is manual vacuum aspiration cannula, provided the MVA is sterile. Okay. So you have to do a plasma sterilization. I don't know how people sterilize. So we do plasma sterilization for the MVA. Okay. Don't try and take it through that steel cannula, that stainless steel suction cannula. In that suction pipe, no, 90% of the contamination of the world is there. Okay. So don't try to take it through that. Take it through the MVA only, which does not get connected to a suction cannula. Okay. So just keep that in mind. Yeah, but I conclude. Shilpa madam, maybe one or two questions.
Yeah, so we are talking about the first trimester abortions, right? Wherein like there is a missed abortion, there is just a CRL which is seen and there is no cardiac activity, or it works the same way to blighted womb also, where it requires only the trophoblast, or it doesn't matter. I mean, what is your thought?
It's the same, madam, because this POC is any which way is a biopsy which is going to come from the syncytial trophoblasts. I mean, there is nothing, nobody is going to take a biopsy from a fetal part or a fetal skin biopsy or anything like that. That's, that's not going to happen.
Okay, so I think you told about the maternal cell contamination with the G banding, which was, I think, quite a common situation that we used to face before.
Very commonly, no? You will get that report when you do the traditional POC karyotyping, and if you just write that and send, 50% of the reports will be maternal cell contamination, or the second thing will be adequate control could not be established, cell culture not possible. Correct? Because see, by the time, what practically happens in India is today somebody has had a missed abortion, diagnosed. So that abortion would have happened, let's say 4 days back. Okay, then they will go home, and these days everybody wants to think about it, read, discuss, and all that bullshit. So by the time they come back to you, it will be another 2 more days or 3 more days. So that 1 week has passed after the abortus has actually occurred. Lot of cells actually undergo necrosis, apoptosis in that. If you study how the POC karyotyping is, it will undergo necrosis in that. From a necrotic material, how do you do cell culture? Understanding, which is why PCR based things on microarray or NGS is much better, because it is just looking at the lysed products any which ways. Understanding, for doing G banding, you need to isolate the fetal cell, culture it, grow it to a particular amount, put it inside the chamber, and then study the pattern. Okay, this you don't have to do when you are doing NGS or array CGH.
So this is, I mean, how does it work if we have to transport this sample to some other place? I mean, is there any specific
It's a
instruction?
buffered solution, madam. All you should remember is that staff should not add formalin. If the staff adds formalin, you are finished. Everything gets fixed. Okay, and the cells get fixed any which ways.
Yeah. So if we do it on a Saturday and if the Sunday the lab is
Put it
closed.
in the fridge. Put it in the fridge between 2 to 8 degrees. There is no problem.
Okay. And so does it matter if we diagnose it, say, by gestational age, if the fetus is about 12 weeks and if it is corresponding only to 8 weeks? I mean, do we counsel them differently, saying that the
No, same.
same this thing? Okay. And also for G binding, how much it costs? I mean, do you have any idea?
Less than 10,000.
Okay. Okay. And for balance translocation, you said like PGTA would be ideal.
Any
So,
translocation, forget balanced. Any
huh,
translocation, any inversion, any shortening, lengthening, all these you pick up, no? In all that situation, PGTA is a good option, madam. You have to counsel it.
okay. What is the commonest POC karyotyping report that you have come across?
Trisomy
Yeah, yeah. So trisomy and
or monosomy. So that's what I was saying. Deletion and all these things. Trisomy or monosomy. Monosomy 2, monosomy 9. All these types of random things are common. And it is
mhm.
good, no. It has to be an abnormal report. Good. If the report
Yeah.
is abnormal, you don't have to do anything. Finished.
Exactly. So also tell me this, like when you send the karyotyping of the couple, and there will be like, written in some like undecipherable way where like P53, Q10, something, something, and then they will write that this is not a major gene factor. It can be considered as a normal variant. So in
Yeah.
such situations, what is it that you do?
No, you consider it as a normal variant. Give the couple an option for PGTA. Simple.
Okay. It's not simple. How can you say it is simple? It is like, it is like a 4-page report wherein like, you keep reading, 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 and you will not understand. Um, uh, okay, fine, leave it. Uh, yeah, I think so. So you don't believe in like, at say like 15 weeks or 16 weeks, if there is a recent IUD, you don't believe in sending fetal skin or fetal part or anything, even the placental tissue you think is enough, even in such situations?
Yeah. Actually, if you really want to do something, no. See,
Mhm.
in IUD, it is a tough thing. Okay. See, if there is an anomalous baby and you want to plan something for the next baby, you should plan to do amniocentesis with exome sequencing. Simple. You will come to know everything about that child, what has probably gone wrong. And if you want to really look into more detail, then you should do fetal autopsy. Okay.
Mhm. Okay, and can we use misoprostol and can we just do a routine DNC, what we do to collect the sample and put it in that buffered solution?
Yeah, yeah. I mean, why? What else will you do?
No, I thought I'll ask a simple question so that you get confused.
Yeah.
Okay, tell me this. Does this need the buffer solution? Does it have gentamicin in it? Is there an
Yeah,
antibiotic?
sometimes it does. It has to have an antibiotic to prevent, the contamination of the surface fluid which comes along with it. So gentamicin is added, but it is pre-buffered. You don't sit and put normal saline के अंदर 1 vial of gentamicin and think everything will be good. एक तो gentamicin अपन ने किधर से मंगाया उसमें भी तो लफड़ा है ना. So better it is that it is prefabricated gentamicin which is put inside.
So they sent pre-filled these the tubes that we have to collect it from, I mean, any of
There is a
these.
kit for that.
Yeah. So, and the kit also has an expiry. So what is
Of
it that
course,
the expiry about?
preservative will go, no. Buffer will get lysed inside, no. It will not be able to preserve the cells only, madam.
Yeah, yeah. Okay. Is there any
But
particular?
I'll tell you one nice practical tip what you should do. Okay, this is what we do. You want to follow, you follow. Don't follow. No problem. Once that MVA syringe में product of conception comes out, no. Okay, best before you actually transfer it inside that karyotype ka thing. You just put it inside our normal saline and just spin it a little. Not spin, matlab spin nahi. Just shake it a little. What happens is, all the blood and all that debris and all that, it settles down. Lot of these fetal products, they stay floating. Okay, you take that product and put it inside. That is the best to do. Okay, otherwise blood also goes, everything goes inside that and it gets contaminated and lysing becomes difficult because blood itself causes lysing. So this is just something which you have to keep in mind if you want sexy reports to come out of it. Good reports to come out of it. Sorry.
Yeah. So is there any particular amount of tissue that is required for reporting? What words you are using? How can you do this?
Sorry. No, no such thing. I mean, there is no particular amount because any cell can be cultured to unlimited amount. And same thing is with PCR. So there is nothing like that.
Okay. When a patient asks between POC karyotyping, we don't want to do POC karyotyping. We want to do just parental karyotyping. Okay. I mean, between these two. So do you say that you can choose, or is it not choosable? Is it not interchangeable?
Nobody will talk like this to me. I will straight double the charges of DNC.
No, you
They will
can't.
not talk like this. No. They have to listen to what is important. They can't apply their own head.
No, as a consultant, see, between choosing the POC, see, I will tell you,
Couple karyotyping, listen to me. Couple karyotyping has a specific indication. Couple karyotyping should not be performed when there is an aneuploid embryo. You really don't need it. Correct? You don't really need to do a couple karyotyping when the embryo is aneuploid. There is no treatment needed based on POC karyotyping. Correct? If the embryo is euploid, again you don't need it. It's a couple which is giving euploid embryos, right? So somebody can argue on this that yes, sometimes if there is a balanced translocation or an unbalanced translocation, 25% of the embryos are still normal. Of course they are normal, they'll come out to be euploid. Correct? You can't substitute one for the other. That is for sure. You need to design couple karyotyping to be done in cases of inversions and translocations or trisomies or something like that, but don't give one as a substitute to the other. That's
No,
not
no,
possible.
no. I think let me just put the practical problem. See, if there is a 6-week missed abortion, okay,
Yeah,
and you want to do a medical method of abortion, or
yeah,
if you want to do a surgical method wherein you get the POC for karyotyping, okay,
correct.
in those situations, do you just go ahead because the patient may not be willing for the surgical option just to do
So
the POC karyotyping?
no, madam, see, in that situation, if the patient is not willing for POC karyotyping, then karyotyping of couple is not the option. Then if in case the couple is really serious, then they should do exome sequencing, because exome sequencing will give an answer to almost everything. They should not come back to you and tell you, oh, couple karyotyping is normal, now what? Huh? ऐसा नहीं होना चाहिए. If
How
they
much
did
is
not choose the
exam?
correct treatment, only 55,000. So
Okay,
when
but
you tell this, no, automatically they will come for POC karyotyping. Okay, then they will start listening to you.
no, see the POC karyotyping, if there is an unemployed, how can you speak like this in a class? You have to be serious. Okay, if at all, if the POC karyotyping is, I'm sorry, unemployed, don't you think we have to evaluate the couple? I mean, don't you think that there could be some problem in their gene
Yes,
makeup?
you are right, madam. But for that, we need to know what is the aneuploidy, right? For example, I can say the embryo is aneuploid when, let's say, it's a trisomy 21, and I can say it's an aneuploid embryo, right? It has some significance, correct? No, I can also say trisomy 2 is an aneuploid embryo, isn't it? But trisomy 2 are these, these are those point mutations which occur during development. And these point mutations which occur during development might not get repeated. So that is the reason when you are just reporting an embryo as an aneuploid embryo, you need not go ahead and test the couple or investigate the couple further because it was a bad embryo to start off with.
Okay, forget about the exome sequencing. What is the role of parental karyotyping in current scenario? Forget about the exome sequencing. Only parental karyotyping, which is done for 8,000 rupees or even like 6,000 rupees for the couple.
Yeah, good role. See, in today's time and age, I think parental karyotyping, if we eliminate POC karyotyping, let's not talk about it for 1 minute, okay? Parental karyotyping is very important because it gives you that first line analysis when you are treating a couple. Very simple. For example, you have a couple, let's say, who has a short arm, long arm inversion on, chromosome number 11. I'm just putting a random thing, right? If you pick this up, no, madam, on the pre-fertility evaluation or something like that, correct, then it is a great thing because from the first day itself you have counseled the couple that okay, you are going to require to push in yourself for a PGTA or something like that, correct. You don't wait for those 2 abortions to happen. But see, in the standard of care of Indian practice where people are fighting to do IUI cycles at less than 10,000 rupees, if you are substituting a test of karyotyping of the couple for let's say 7 to 8,000 rupees, then practically it does not make so much common sense, which is why such protocols are designed to go and test the couple for a karyotyping only when it is absolutely deemed necessary. Hai. Otherwise, if we randomly test all preconceptional couples for karyotyping, it is not justified. Something like that.
Yeah. Yeah, I think so. So even like, even if they keep it for a week and then send it also, the report would be the same, you think? The microarray?
Yeah, because microarray is based on amplification of the tissue. Correct. Correct.
Oh. Okay. Yeah. I think we are good. So what happens if there is no buffered solution available at that point in time? So how long can it be kept in a normal saline solution till we get the pre-filled
4
tube?
to 6 hours.
Okay. Yeah. Sure, but the most of the problems happen during the weekend, because everybody wants to like do the DNCs in the weekend and then we get stuck. But I think those are all logistical issues which we have to sort it out prior. Yeah, I think
You would always know if there is a DNC where you have counseled somebody for a product of conception karyotyping. You will almost always know it.
No, not really. See, they come on Tuesday and they will say they will go home and think and they will discuss with their family and they will come on Friday night saying that they want the DNC on Saturday. Okay. And then we realize there is it is expired or if it is not there or it is misplaced. And then we end up in scrambling in the last minute and trying to figure out the jugards which we can do. Okay. Anyway, I think
it's simple to keep a kit of POC karyotyping to whichever laboratory whom you are sending it to. It is better to keep a kit 2 months before expiry, give it back to them. Just in case it is like this. No, what will happen is they also know some of the kits would expire. Or you should have like how we do. We are stockist for near expiry kits. Understanding? So what happens in that is no, we don't send so many. But what happens is we are stockist for that. We are stacking some of these kits with us. ठीक है. It is available at 1/50th the cost of the standard kit. All right, 1/50th. Okay. And you can stock it. It is equally effective. It works beautifully well. And results are fantastic.
Sure. That happens only in street clinic. Okay, thank you. Yeah. Thank you. It was a good one. We'll meet again for the next session. Thank you.